can mute and yeah.
I'm confirming I don't see this.
Yenisel, do you want me to start?
Yep. Okay, so I think we're ready. So yeah, let's welcome first Dr. Kathleen Sluka, who is one of the co-chairs of the HEAL Strategic Planning Committee.
Okay. So you should be able to hear my slide. Welcome to the HEAL Strategic Planning Committee Biomarkers and Predictors Subcommittee. And thank you all for attending. I want to
Dr.
give you a
Sluka,
little.
can you just share the other screen right now?
Oh, am I sharing the wrong
Swap.
one?
Swap, yeah, the displays.
I thought, all right, hold on a minute. I'll find my swap button. Oh, shoot. I thought I should. All right, let me try that again. I'm sorry. It's supposed to go to screen 2. Okay, I'll try it.
If you share what a presentation is live, that one should go.
You got it?
Yeah, I think so.
Thank you.
Now? Are you seeing it?
Yes,
We're still seeing the side, so you need to go into present
I'm not seeing the
presentation.
whole.
I don't understand that. I can't get it to the right screen for some reason. All right, try one more.
Kathleen, let me
Barb-
know I have it ready for you if you want me to share it for you.
All right. All right, now it says screen 1. Share. Okay. Do you have the right one now?
Yes.
Okay, sorry about that. So anyways, welcome again. We're at the Biomarkers and Predictors Subcommittee. And we're going to give you a little overview of the HEAL Initiative strategic planning process and what you will be doing, what we're doing today. So just to remind you, the HEAL Initiative is an effort by NIH that seeks to come up with scientific solutions to deal with the opioid epidemic and chronic pain. We're particularly focusing, our subcommittee and our groups are focusing on the chronic pain. The HEAL initiative was initially launched in April 2018, and you can see that they funded over $3 billion in pain-related research. This includes multiple institutes, centers, offices across the NIH, And I think it's important to remember what the HEAL Initiative mission statement is, which is to reduce pain and the risk of opioid use disorder by developing safe and effective pain treatment and prevention strategies to improve the quality of life for all people. And with that in mind, we developed a strategic planning committee to look at a number of factors that we feel are important to propel the field forward. And these were somewhat arbitrarily put together, but wrapped around different groups. We realized there's a lot of overlap between different committees. So this committee is chaired by myself and Rob Giroux, and we have Michael Falcon on the executive committee, as well as a person with lived experience. And we've divided into these 7 subgroups: the HEAL equity and pain across the lifespan, non-addictive therapeutics development, pain and biomarkers, which is where you are today, optimization of interventions to improve pain, implementation in health services. And then we have a couple of very cross-cutting areas, including the intersection of pain and substance use disorder and pain research, workforce and training. There will be a series of 7 workshops from now until the 6th of December that we encourage you to attend any or all of these. And it's our opportunity to get feedback from the community. You can get more information. There's a nice QR code for you. You can get more information and register for any of these at that site. So we have met as an executive committee. We formed these groups. The groups have been working hard behind the scenes to come up and think about what these research priorities are. After our work groups, each of these work groups will put together a draft of research priorities. We have a request for information from the workshops, from the areas that you can incorporate, and there is an email at the bottom that you can send information to. Please send your information. We look at all of this information. We've collated it on all of these, and we're trying to incorporate everybody's input into the priority areas. In January, we're going to refine and prioritize all of those research priorities. And then by February, we hope to have a draft of the HEAL Pain Strategic Research Priorities that we will present to the NINDS Council and other NIS advisory councils for input. And the hope is to publish this between March and April of 2025. And then NIH will take all that information and develop funding opportunities for 2027 and beyond to keep the HEAL Research Initiative moving forward to get the best research we can that will solve the HEAL mission. Again, feel free to send comments. We're looking for your input today. There's ample time for discussion here, so please speak up. Use the question and answer to ask your questions. Use the chat, and we will all be looking at the chat. We will respond to your messages, hopefully in the chat. And this is an opportunity for open communication. Thank you very much.
Great. Thank you so much, Kathleen. So can everybody see my screen? Yep.
Yes.
So thank you again for that welcome and introduction and background to the HEAL initiative. And now Dr. Vivianne, Tawfik, and I will focus again a little more on specifically in relation to biomarkers and predictors. We're both extremely grateful to our subcommittee members who are here. They represent a wide spectrum of expertise across the research continuum, from preclinical to clinical translational research, and also including 2 individuals with lived experience. Let's first start though with the definition of a biomarker. We are using specifically the FDA NIH biomarker working group definition that a biomarker is a defined characteristic that is measured as an indicator of normal or biological processes, pathogenic processes, or biological responses to an exposure or intervention, including therapeutic interventions. And they could be molecular, histological, radiographic, or physiological characteristics. In relation to pain specifically, pain biomarkers can be thought of as prognostic. Is the person likely to develop chronic pain? Or diagnostic, what type of chronic pain is it? Or predictive, is this the best treatment for the person's pain? Pharmacodynamics, what's the best dose for an individual? Or recurrence, which is how likely is it that the pain will return? You probably all know that we should care about pain biomarkers. That's why you're all here, but mainly why? Because, well, they have the potential to help us understand pain mechanisms, but they can also improve clinical trial design by identification, selection of the appropriate patients, monitoring treatment efficacy, developing surrogate endpoints, and helping in personalized pain management. So identification of different pain subtypes, predicting treatment responses, development of safer and more effective pain therapeutics, specifically those that are not addictive, identification of novel targets, monitoring safety and efficacy of potentially novel therapies. So to clarify, this is actually not the first effort in the pain field to move pain biomarker research forward. As Kathleen mentioned, in 2018, the HEAL initiative held a similar workshop that was later published as a consensus report in 2020. Actually, some of the authors are part of our subcommittee right now, where basically a number of recommendations were made, and they included the standardization of biomarker definitions and validation, the development and validation of biomarkers that are reflective of a range of pain mechanisms and experiences, the exploration of multiple biomarker modalities, as well as development and utilization of composite biomarkers from multiple data sources, improving self-reported pain outcome measures, as well as measures and biomarkers that actually address the dynamic nature of pain. They also recommended the exploration of the use of surrogate endpoints in clinical trials, engaging with regulatory agencies early in the biomarker development process, fostering collaboration, data sharing among stakeholders, considering the societal and ethical implications of biomarkers, as well as prioritizing research on biomarkers for vulnerable populations who cannot self-report pain. This year and right now, we're tasked with developing a short list, as Dr. Sluka mentioned, of 3 to 5 research topics that should be prioritized within the biomarker space. Some of you may be familiar with the request for information that was out with a period of public commentary in July, and now this virtual mini workshop that's open to the public. We're hoping to receive additional input on this. We're fortunate and grateful again that members both from our subcommittee as well as from the scientific community representing individuals not only from academia but also industry will help right now exploring this topic further. As we actually would like to encourage interaction and input, please use the chat button on the bottom if you would like to basically have any thoughts or feedback in the conversations. And you can use the Q&A button to ask questions to the different panelists. And again, we would like to encourage both. At this time, I would like to introduce our first speaker, Ms. Kristen Beasley, who is the co-founder and director of the Chronic Pain Research Alliance, a person with lived experience of pain and a member of our subcommittee. Ms. Beasley, thank you again for
Thanks.
joining us
Yeah,
today
of course, thank
and it being part of our subcommittee as well.
Thank you very much. Can you see my slides?
Yes.
Yes, perfect.
Okay, great. So thanks so much for that kind introduction and for asking Christine and I to share a little bit of the lived experience perspective as we start this discussion on biomarkers. As you mentioned, I'm the co-founder and director of the Chronic Pain Research Alliance, and I also have 30 years of lived experience with chronic pain. And although I've experienced pretty much every type of pain, the area in which I work and have most expertise is chronic pain, so I'm going to focus my comments on that area today. So your slide, Yenisel, was much prettier than mine, but we're all familiar with the FDA's types of biomarkers and classification. And while all of these are really important and we need all of them in the field of pain, I'm going to focus my comments on two kind of buckets today to deal with unique challenges that we have in the chronic pain space. And the first is diagnostic biomarkers. So we're all familiar with the fact that right now, the way we classify and diagnose chronic pain conditions is pretty much by anatomical location. But the issue with this is that it overlooks etiology or pathophysiology or underlying mechanisms. So if you look at a figure like this, where you've asked someone to just color in all the areas where they experience pain, it paints a picture of what their experience is, but it doesn't give you much information on what may be going on the underlying mechanism perspective. And clinicians and patients alike, this is the list of pain conditions that this particular person had, or the pain diagnoses that she had received. And clinicians and patients alike will tell you that, this isn't particularly meaningful to them because most of these conditions don't have a corresponding treatment algorithm that goes along with them, right? So just have a myriad of different therapies that could potentially be helpful for any one of these or a combination of these conditions. So hopefully with the advance of science on underlying mechanisms of pain and the development of diagnostic biomarkers, we can get more to a state that you see on the right hand of the slide, where we can identify different pain states and underlying mechanisms, which would give us more information on particular targets. And all this, though this figure is specific to drug prescriptions, obviously this could also be utilized for non-drug therapies. So the second area I'm going to focus on is mainly predictive biomarkers, but a little bit on PD and safety as well, to tackle kind of the second challenge in chronic pain, which is that we have an explosion of pain treatments out there, but we have almost no data on what works for whom, at what risk, and at what cost. And FDA Commissioner Rob Califf has become semi-famous for this quote, saying that unfortunately the field of chronic pain treatment is strikingly deficient in high-quality scientific evidence. He said this in his New England Journal of Medicine report in 2016. Unfortunately, this really hasn't changed all that much since then. So the resultant situation for the treatment of chronic pain, many describe as kind of blindfolded darts. So without having cost, risk, benefit data for different treatments, we have this whole myriad of therapies that could potentially be effective for any particular person. And patients feel like their physicians or clinicians are just kind of throwing a dart against a dartboard to say, okay, well, let's pick one to start with. And then they go through this period of weeks, months, or years in a trial and error process to try to identify what works for them in particular. And just to give you kind of a visual representation of how this plays out in real life, this is kind of my story. Over the course of 6 years, I saw 6 different specialists who all had different treatment recommendations for the particular conditions that I had. Spent up to 25 hours per week going to appointments and doing therapies, and tens of thousands of dollars. And many people, including myself, describe this process as like a roller coaster. So particularly on the drug side, I had to fail 9 times before I found one particular drug that was helpful for me. And obviously, we're all very familiar with that whole process where you have to titrate up on a drug, see what side effects you might experience, get to a therapeutic level, stay at that level for a specific period of time, see if it's effective, and if not, titrate down off of that, wash out over a course of weeks, and try that all over again. And the same can be said for, non-drug therapies as well. We just really don't have a lot of information to say who should be doing what. And I also just want to highlight the emotional roller coaster that all of this results in for patients, because as you can imagine, when you start treatment number 1 or number 2, people are very hopeful, as they're going through this process. But when they get to treatment number 6 or number 10 or number 15, this whole idea of trying something else, trying to be hopeful that something's going to be helpful for you, and then experiencing that it's not, and gearing yourself to do this all over again can be very taxing. So obviously we have a lot of work ahead of us. I wish this was the exception and not the rule, but most patients do experience this type of a scenario when they're trying to find something that's helpful for them. And so the one example that I'm familiar with, and hopefully many of you are more familiar with ones that may be in development right now, but is the one that I know of that's available, but still not very widely used in clinical practice, is pharmacogenetic testing, where we can take, a dizzying number of potential drug targets for any one person and at least identify gene-drug interactions to narrow down or reduce the possible number of medications from which you should start trying this trial and error process. So with that, I'm going to actually turn it over to Christine, who has a lot of experience in this particular area and is going to share her story.
Well, thank you, Chris, and I'll wait for my slides to come up while they do. But it was a perfect, Chris and I talked yesterday really about our experiences, and what I was presenting or looking to present really aligned well with what she was speaking of as well. So I'm going to talk today about my own journey with invisible pain and the future of what I think pain management looks like. So next slide. So just a brief intro on who I am. I'm a patient advocate. I lived with chronic pain for as long as I can remember. Over the years, I've tried every treatment and therapy available, including being prescribed up to 200 opioid pills a month. Despite the heavy medication, my pain never subsided. And it wasn't until a pharmacogenomics test that we revealed that I'm a rapid metabolizer of the CYPD6 enzyme. And I started to understand why my pain wasn't getting resolved. But in addition to the chronic pain from childhood, I've had multiple joint replacements and conditions like fibromyalgia, rheumatoid arthritis, and avascular necrosis that have contributed to the pain. But despite having all of these diagnoses, none of them fully address the issue of chronic pain that I face. Next slide. So over the years, dealing with chronic pain, I faced with the relentless pain and ineffective treatments. There was really a gap, right? Most of my life, we went from just looking at the pain, going into extensive treatments. The symptoms still weren't there. And at one point, I was able to have a pharmacogenomics test, which I received through a study. We found that because I metabolized this compound differently, those opioids were ineffective. Basically, my genetic counselor told me it was like me taking Tic Tacs. And so we were really looking at other alternatives. So next slide. So my coping mechanisms over my lifetime as a kid, I learned that people did not want to look at, right, or deal with people that were in chronic pain. And so I had to develop mental strategies as a child to cope with the pain. Again, we went to the high prescription doses, but at the same time, I was also sent to a psychosomatic clinic, making me doubt that what I was feeling was even real. So even though the pain wasn't, or the treatments weren't working, we then turned to cognitive behavioral therapy. Through the CBT, I really learned how to compartmentalize that pain more in depth than I had throughout most of my life. And while this approach didn't eliminate the pain, it did provide me with tools to help manage it effectively. So next slide. So this is basically a quote: my baseline pain levels remain high. I am always in pain, but the fact that I look healthy and don't look like I'm in pain really does have a negative effect on things. And so early on, I realized that people were uncomfortable around someone in visible pain. And this is where I learned to hide it. further complicating my interactions with healthcare providers. Next slide. I ended up at Stanford at one point in a coordinated care model. And I will tell you that that coordinated care model has been something that has helped drastically. I have a team now that is willing to look at research and involve other studies or researchers that might have answers and looking at my care in a very different way. And that's my neurologist who did an amazing job. I thought a lot of this was in my head. She confirmed that it was in my head, just not in the way that I thought it was. And so, next slide. So the genetic testing and personalized treatment is something I fully believe in. The pharmacogenomics study, not only with pain meds, but with multiple medications, helped me determine that I should not be taking a lot of these medications. I have joint replacements, toxic encephalopathy, and macular degeneration based on medications that were taken to treat the symptoms of my condition, not even touching my actual conditions. So looking
Sophia,
did
can you unmute?
Did I mute myself?
Yeah.
Sorry, I hit the wrong button. But the I don't know how much we missed, but the pharmacogenomics test really helped, not just with the pain meds, but also realizing the damage that other medications had caused. So I don't know if you heard the damage, but I have multiple joint replacements. I have toxic encephalopathy, and I've lost my night vision, all from standard of care, treating symptoms and not even touching my original diagnoses. And so I really think that pharmacogenomics and personalized treatment plans need to be included and looked at when we're looking at pain management. Next slide. Some of the different pain management approaches that we've taken, and I think that should, and my time is up, but I'll go through here. The pharmacological and non-pharmacological options need to be explored. Therapies like cognitive behavioral therapy, physical and occupational therapy, lifestyle modifications, mindfulness-based interventions, and patient education and support are key. And next. And then I'll leave this, we'll pass out the slides later so you can see this, but really the advocacy and education are important here, making sure that patients realize and understand the options that are out there so that they can drive change and find solutions for themselves. And I think my last slide, hopefully, yes, is a holistic approach is needed. And by advancing our understanding of pain biomarkers and integrating personalized medicine into practice, we can offer hope and relief to countless individuals like myself. And I'll leave it there. Sorry, I muted myself in the middle.
Thank you so much, Christine. So now we will move on to Dr. Peter Grace, who is an associate professor and chair of the MD Anderson Cancer Center. And his slides are up. Thank you, Dr. Grace.
Thanks, Yenisel and Viv, for the opportunity to share today. So my research program uses preclinical models to understand how communication between neurons and immune cells contributes to different chronic pain conditions. And we also have a very strong interest in identifying therapeutic targets and in preclinical drug development. And so biomarkers really intersect quite closely with these themes, and I'll share with you a few thoughts today on how preclinical models of pain can help support the development and the use of human biomarkers. So first, by way of introduction to preclinical models, these are really vital to pain research. And when I talk about preclinical models, I'm talking about the most common ones that we use, which are typically done in rodents. I think that they are tremendously powerful tools to understand the cellular and molecular mechanisms of pain. And that's because we're able to precisely manipulate those factors using specialized tools and being able to study them in vivo to really understand mechanistically how they contribute to pain. The second feature is that we're also able to access tissues that we simply cannot in a living person. And we can assay those cells and molecules, again, using really advanced techniques to gain insights that we can't in human populations. So these unique features then of preclinical models can be applied to biomarker discovery and to the development of these biomarkers. A second key strength of preclinical models is that we're able to evaluate experimental interventions in these models, both ethically and cost effectively. So something else that I'll elaborate on shortly is how implementing biomarkers in preclinical studies may enhance their translational potential. So I'm going to talk a little bit more about some of these topics. And rather than focusing on some of the specific biomarker categories that you've already heard about, I'm going to talk more in generalities about how preclinical models can enhance these efforts. So this is the chart of the different steps and processes that are required for discovery through clinical use of biomarkers. And this is from the consensus statement that Yenisel referred to earlier. This is a really great paper that I encourage everyone to read if you haven't already. And I think that preclinical models really have a unique ability to contribute to the discovery and to the development of biomarkers. So as an example then of how preclinical models can contribute to discovery, I've already talked a little bit about some of the advantages of preclinical models. Additionally, they offer a homogeneous study population. That is, when we're using mice, they're typically similar age, strain, and so on. We're able to control the induction of pain, the duration of pain. And then we have fewer confounding variables such as comorbidities and treatments. And so at least starting from this highly reductionist point, we're able at least to identify candidate biomarkers that could be then developed by adding complexity as we move into different models and then eventually into the clinic. Additionally, we are able to access tissues from the central nervous system, as I already mentioned, and from here then we are potentially able to identify markers that could be accessed in the periphery, but to determine whether they reflect changes that might be occurring in the central nervous system. And so we performed a study a few years ago now where we really did just that. We took rats in this case that had graded peripheral nerve injury that resulted in varying degrees of pain. And we were able to take blood and spinal cord tissue from these animals, do a transcriptome analysis to look at the different genes that were expressed in these two compartments across the whole distribution of pain severity, ranging from mild to severe, resulting in these correlations. And from here, then, we were able to identify gene expression in the blood that was correlated with the degree of pain in these animals. And so these could potentially serve as biomarkers in their own right. But we were also able to correlate gene expression in the spinal cord. And we did find a subset of genes that had overlapping expression. So they were up or down regulated in both the blood and in the spinal cord as well. And so I think it's genes in this particular category that really highlight the unique strength of starting in biomarker discovery within animals. And so hits such as these, and there are other studies as well from other groups that have taken similar approaches, then can be followed up in subsequent preclinical and clinical studies. We can also go the other way. So there are biomarkers that have been identified in clinical studies, and I'm showing just a couple of examples here of different gene variants that are associated, for example, with a risk of developing chemotherapy-induced neuropathy. There are others whose gene expression correlates with the presence or degree of pain, and other proteins such as immunoglobulins that are upregulated and predict the risk of subsequently developing neuropathic pain. These have the potential to serve as biomarkers in some of the categories that we've already heard about today. What's acknowledged by the authors of these studies is that this exploratory approach can identify biomarkers that don't have known functions in chronic pain. And I think this is a very important and insightful approach, but it is necessary, I think, to really understand what the biological function of these putative biomarkers is, because that will then help us define how these biomarkers could be used, their context, as well as their specificity. And as an example of that, neurofilament light chain is a protein that is gaining considerable interest as a biomarker for chemotherapy-induced neuropathy. This is a biomarker that was first identified in neurodegeneration, such as Alzheimer's, and it's a marker of axonal injury. And so we're fortunate that we already understand how this protein is related, but axonal injury may or may not be associated with pain, although it is associated with neuropathy. And so it's important, I think, to understand what the function is of neurofilament light chain or of any biomarker, really to guide its use. Because in this case, it may not be a good biomarker of pain. It would potentially give a lot of false positives. But if it is there as a pharmacodynamic marker, for example, to look at neuroregenerative treatment, then it could be a very effective biomarker. So for the reasons that I elaborated on earlier, preclinical models really serve as a unique gap here, or a niche where we have the ability to evaluate the function of potential biomarkers by taking them from the clinic back into preclinical models. And then finally, I think that biomarkers could also be incorporated into preclinical drug development. And so the reason that we're all here is that we don't have good treatments available for management of chronic pain. And unfortunately, preclinical models have not had a great track record in translating some of these agents into the clinic. There are a number of reasons, potential reasons for that. And one other one is that we typically don't measure the same things in preclinical and in clinical studies. We rely on patient-reported outcomes in humans that, for obvious reasons, we cannot use in preclinical studies. But I think that biomarkers could really bridge this gap by unifying the measures across preclinical and clinical assessments. And one example here is how we could use imaging to do that, and really to try to get at some general mechanisms. I'm showing here an example of PET imaging for TSPO, a protein that is upregulated in neuroinflammatory states that we're able to measure in clinical populations as well as in preclinical populations, showing as well response to potential drug treatments. And doing this would then allow additional mechanistic insights into these interventional clinical trials. So I know that I'm over time, so I'll just quickly wrap up by saying that preclinical models, I think, can really work in concert with clinical biomarker discovery and development. That we may be able to discover biomarkers in preclinical studies and then use these preclinical models to understand mechanism and guide their application. And additionally, by incorporating biomarkers into preclinical drug development, we may enhance the translational potential of those studies.
Great, thank you,
Thank you.
Peter, for providing that information and perspective from the preclinical side. We're now going to hear from Susan Dorsey, who's a distinguished university professor in the Department of Pain and Translational Symptom Science at the University of Maryland. Go ahead, Susan. Your slides look great.
Thank you. Great. So I was asked to talk about the use of multi-omics or omics in the quest for biomarkers that can not only inform pain research, but also eventually, as our hope would be, clinical practice. So this is a figure from the consensus paper that was published in 2020 that Yenisel and Peter both mentioned, that arose from the 2018 biomarker meeting. And, you know, the support for the quest for biomarkers is certainly clear. And as has been mentioned, there are biomarkers that differ based upon whether we're looking for someone's predisposition to develop chronic pain from acute pain, so acute to transition to chronic pain, or the chronification. And then a second sort of subset of biomarkers looking at either treatment response or failure, and what works for who and when. And I think our both Christine and Chris talked about that as well. So I'm going to focus on the predisposition aspect of the biomarker development. So when we think about omics, most people think about, you know, DNA to RNA to protein, but there are obviously many more omics. This is not an exhaustive list of omics technologies that are being deployed in studies, but we have the microbiome, lipidomics, metabolomics, epigenomics, and certainly there are others. So this is just a subset of those. And they can be assayed from a variety of human sources. So for example, stool samples can be harvested to look at the microbiome, hair cells, and in fact, nail beds can have protein extracted and looked at proteomics. Intra-articular joint aspiration can be used to look at gene expression or protein expression. The oral microbiome and DNA and RNA can be obtained from saliva, coarse urine, aspiration from the intrathecal space, and then blood. So there are a variety of sources that we can interrogate in humans. So I was asked to give an example from our human studies and a couple of lessons learned in terms of the biomarker development. So the first thing I want to talk about, and this is a low back pain study, we followed patients or participants at baseline and then across time over the 2-year period. So these were patients that had an acute back pain episode that was new. They couldn't have had chronic back pain or back pain for the prior 6 months, and there were other inclusion and exclusion criteria to hopefully make this as clean a study as possible. The orange shaded blocks of time are those time points in which they came in for in-person visits, and then the other visits are online. And so I think the first point I want to make is that having a longitudinal or prospective natural history study is really important when we're thinking about biomarkers, not just at baseline, but how they might or might not change over time. So you can see here we collect a variety of data, sociodemographic, clinical, and then we do administer a number of questionnaires that get at the clinical pain phenotype. And then we look at common comorbid conditions such as mood, reactivity, disability, stress. We do a blood draw since we're looking for biomarkers. And then we do neurophysiological testing at each of these in-person visits. And Peter mentioned the QST and the difficulty doing that in rodents. This is just a diagram of our protocol that we based this upon the German Research Network, a neuropathic pain protocol. And what we're doing when we're looking at quantitative sensory testing is we're looking at the responsivity of the sensory fibers to either thermal or mechanical stimulation. So I'm not going to go through this in any detail. It's just to show you the order of testing and how we think about the testing. And if we want to, we can talk about this in more detail later. So this was a small study, a preliminary study that we published a number of years ago, and we have now just completed the larger study that includes many more participants. This just gives you an idea. We basically had 3 baseline groups. We had normal healthy controls. We had folks that started out with pain, back pain, and they acutely resolved within 6 weeks after the insult or injury. Then we had chronic patients at baseline, and then we had chronic low back pain patients at 6-month time point at which the chronification had set in. And so what I hope you can appreciate is, number one, we did find things that resonated with prior literature, which I think is important when we're looking at our phenotyping. So as you can see here, our healthy controls don't have any pain on a visual analog scale score. The acute pain patients that resolved had lower VAS scores on pain than did the chronic or the participants that went on to develop chronic low back pain. And that's consistent with what's been shown in the literature. And the other thing we noted was that, much like what's already been shown again, acute resolvers were more likely to be taking NSAIDs or Tylenol to manage their pain than those that went on to develop chronic pain. And in terms of the neurophysiological testing, heat pain tolerance was significantly different at baseline between the normal healthy controls and the acute and chronic pain resolvers. And then at the 6-month time point, you can see a little small drop in heat pain tolerance in the 6-month group, meaning that to the same amount of temperature stimulus, they feel pain at lower levels, meaning they have hyperresponsivity. So we did transcriptomics in this study, and that's the study of all the genes that are expressed in the particular cells that we looked at, and in this case, it's bulk blood. And we took all of the transcriptomic profiles of each participant, and we did a principal components analysis, and you can see that it broke into 2 branches, essentially, 2 main branches or 2 different groups. The first group on your left in pink and green being normal healthy controls and the acute resolvers, and the second cluster on the right in orange and purple being the baseline chronic pain patient transcriptomic profile, and then the 6-month chronic pain patient profile, suggesting that these transcriptomic profiles tended to cluster fairly decently. We found that the majority of these transcripts were protein coding, although you'll notice there are many other types of RNAs that you can look at, including microRNAs, pseudogenes, ribosomal RNAs, and so forth. So we found these are volcano plots. Looking at the y-axis is the negative log fold change, FDR corrected p-value. The higher the number, the more significant. The y-axis is log fold change, comparing one group against the other. Each dot represents a particular gene. And you can see that many genes were different between the acute versus the chronic low back pain participants at baseline, and also between the healthy control versus the chronic low back pain participants at baseline. So we looked at the top 100 genes that were up or down regulated significantly. And this is showing you the baseline values for each group. The healthy controls are on the left, the acute resolvers are in the middle, and at baseline, the participants that went on to become chronic pain patients are on the right. And so what I hope you can appreciate is that the molecular footprint, as we refer to this, is quite different in a healthy control versus an acute resolver than it is in a participant that went on to develop chronic pain at the 6-month time point. The other thing we noticed is the direction of the genes were pretty consistent, and they were elevated in many cases, or they were depressed in other cases. If you look at the graph on the right, we didn't see a lot of genes that changed from the baseline to the 6-month time point, meaning it almost seemed, at least in this study, and we're going to try to validate and confirm this in the larger study, that sort of that baseline footprint could be what could be helpful for us in predicting which folks will come in to the clinic with acute low back pain and they will be resolving, and which participants are at more risk to develop chronic pain. And that way, eventually, we could tailor treatment so that we know how to best effectively relieve pain and prevent chronification. So I was asked to sort of think about what are some pressing issues in human omics studies that are trying to identify biomarkers. one of the first things is most studies, except the OPERA study, which was a temporomandibular joint disorder study that Bill Maxner did, most studies don't profile any omics signatures prior to an injury or an event. So it would be great if we could, sort of follow folks over time and then they develop the condition, but we have a baseline transcriptional profile or omics profile on them prior to the injury. So we don't know at the baseline that we measured whether it was due to the injury or insult or whether that was their sort of baseline transcriptomic profile. The second is most studies use one omics methods. As I just showed you, we looked only at transcriptomics and not a multimodal or omics approach. So I think considering multi-omics could be important. Most studies are cross-sectional rather than the longitudinal study that I showed you. So questions around the value of cross-sectional studies versus these longitudinal studies, and really digging into the data to figure out whether these genes and transcripts and proteins and other omics are changing over time or whether they're relatively stable. Two other points: what tissues or cells make the most sense to profile? We profiled about blood, but one could think about profiling particular cell types or even extracellular vesicles as potentially more informative. And then which method of profiling within a particular omics technology. And so I'll just end with this: additional future considerations. It would be great to take all of the phenotype data, the molecular data, the transcriptomic data, the neurophysiological data, and put it into a black box and have it spit out that predictive or prognostic biomarker of the chronification or the potential for chronification. But the computational infrastructure and informatics expertise around machine learning and AI methods, I think, is an opportunity for further development and refining that process. And then I think the other issue is, this study has a relatively large sample size. Not the study I showed you, that was the preliminary, but the study we're now analyzing data from. And is that really the best approach, is to profile many people over time, or smaller sample size studies, for example, the N of 1 approach, where you deeply phenotype single persons and then profile their omics and their imaging and all the other multimodal biomarkers that one might imagine to get more detail. So I just leave you with a couple of questions. I'm sorry I ran a bit over, and I'm looking forward to the panel discussion. Thanks.
Great. Thank you so much, Dr. Dorsey. So next we have Dr. Howard Scher, who is the D. Wayne Calloway Chair in Urologic Oncology. He's also the head of the Biomarker Development Program, Office of the Physician-in-Chief, as well as member and attending physician at Memorial Sloan Kettering Cancer Center. Dr. Scher, thank you so much for joining us today. We
Thank
really
you for
appreciate
the invite. Let me get to, let's see. Just to share the screen.
I'm sharing your slides for
good.
you.
Oh, okay, even better. I can't get into trouble. Let me just close that. So you have them now, no problem? Okay, so they're there. Terrific. So thank you for the invitation. I think it's been really interesting looking at the world of pain. My focus at Memorial has been on prostate cancer, where pain has been a major factor in unfortunately in the illness of the men that we are treating. And it's really been difficult to actually do clinical trials. And what I'd like to go through is to put this in the context of how we develop drugs, because in fact it's the same. And one of the things that I think would be interesting to talk about is what kind of statistical designs are used in order to develop the validation process. Next slide. iDrive or you? Okay, this is my disclosures. Next slide, please. So the development, I was running the GU oncology service here for 25 years, and I was told that we would ask you one day to step down and you'll have an institutional position And I was asked to develop a biomarker program. And I should add that when I started here, there was no PSA test, which is one of the most commonly used for to pick up the diagnosis of prostate cancer. So what we really were looking to set up was a way to take a biomarker all the way through the regulatory context that requires for it to be utilized. And really, we now have the infrastructure, but one of the key things is the importance of the actual biomarker itself and how strong is it, how valuable is it. And for most of the molecular testing that we're doing now, here our group that does the genomics has done about 120,000 samples, is once you start a trial with a particular assay, you have married that assay. It can't be changed. And once you start, you can't turn back and start over. And what's really thinking about how we actually use the test, you have to make sure that the assay or whatever device is needed to generate it is really fit for the purpose of the specific, what we call context of use, which is the decision that we're going to make with the biomarker result. And really the whole idea that we do here is how do we make better decisions to improve patient outcomes? Next slide, please. Okay. So really, for me, the interest in what to do in terms of biomarkers were what were the problems that I was seeing with our patients. So as you heard earlier, which I'll go through again to a degree, is again, what are the contexts of use? What is the disease? How do you understand an individual patient's disease? Here we're now getting into the area of symptoms, where the biomarkers many of the biomarkers have not gone through the same validation process, which is really critical to show its clinical utility. So what we do now, as cancer changes over time, we're very careful to serially monitor not only what's happening in terms of treatment, but how the biology of the tumor is changing over time, which has become a big issue, not dissimilar to antibiotics if they're not effective in eliminating an infection. So really the key here is how do we make these decisions and what we're going to study and how we're going to do it. Next slide, please. Okay, so what I'm going to do now is really show the commonality of what will be done here in terms of pain and how it's pretty much the same of what the approaches that we use for the development of a drug. And what is really essential is the clinical trial, which gives the clinical validation to show that the biomarker makes decisions, which improves a patient outcome. And as you heard earlier, this follows the best resource of the FDA. Next slide. And you can really break this, if you look at how a drug is done, it's for a specific indication, where in a patient's history with a malignancy, are better drugs required. This is the indication of how the drug should be used. It's the same for any biomarker. What is the decision you want to make? Key with using a drug is the formulation, and key is really what is the measurement, how reproducible of it, how consistent of it, and does it give us the information we need in order to make the decision. And the goal is ultimately to show clinical benefit, or we call utility, for a drug. It's to improve outcomes, and what you're really looking to do is to show that by using the biomarker result, a patient outcome is improved. And what is extremely difficult is really showing the clinical utility. And another issue here is where does the funding to do these kind of trials come from? If it's a drug, that's clear that there is a way for a company to improve. But what's really challenging when you're looking for symptom biomarkers, it's really hard to get the support to do the full clinical trial that's needed to show its utility. Next slide. Okay. The most critical step is, as you can see, I've been heading in that direction, is how reproducible is the particular biomarker that you're using. If we think in terms of the assays that are done in a clinical laboratory, they have to essentially be bulletproof in terms of their performance. And this is an important factor that has to go into any biomarker, any description, pain intensity, etc. Are these the ones that we really should be using as the target for showing that they are helpful in terms of us making decisions to improve patients' outcomes? Next slide. So you look at this in terms of a laboratory, even if let's say you draw a blood sample, what kind of tube do you have to use? How quickly does it have to get to a lab? All of these can affect the ultimate biomarker result. And I'm not sure how this is really handled when you're looking at quality of life or symptoms in patients, which is really, again, I can't say enough about how important it is to be able to trust that biomarker for the decisions in which you're trying to show their value to patient management. Next slide. Okay, so really, this is really the most clinical step of things, and it, as I just mentioned, it's really the performance of what measurements you're using, and this really requires showing its reproducibility, that it gives you the information that you are using. And just in preparation, I was looking through publications, and for many of the contexts that I've heard of, the number of publications is in the 4 digits. I'm not sure that they really have, many of them do not have statistical designs, so it's really hard to put the information into a context that can change how you're using them in clinical management. Next slide, please. So as I mentioned earlier, in terms of fun, this is all the information we want, but really nobody wants to pay for it. That's the same in a lot of the assays that we're working on. And I would just, I know, having worked with quality of life, it's a hard issue as well when you're looking at patient management. Next slide, please. So if you think about the actual biomarkers themselves, this is just a very small list of it. We've heard a bit about pain intensity, but individual patients may not interpret that the same way. We heard about analgesic use. I would be interested to know how often some of the genomic profiling is used, or what is the indication to do so in management of a patient for specific classes of analgesic, which I think is very important. What's the index that we're looking at? There's one from the WHO where they look at a combination of pain index and the analgesic, combining pain and the analgesic scores. And also in many cases, there can be a inflammatory component contributing or causing the pain. And again, how is this looked for, and how often should that be done? Next slide. So this is sort of just breaks down the best resource. We think of the first set of biomarkers pre-intervention. We heard about what is the diagnosis, what is the prognosis, what particular drug would be optimal for an individual patient. We heard, again, a very important study when I learned about the GYP2D6, something I was totally not familiar with, or even to look for it. After the indication, we start looking to make sure that it's safe. We want to dose it properly. We want to show it does something. But how do we monitor this, and how do we design the trial? And one of the interesting things now is that in the best resource, there's this reasonable likely surrogate, which is a lot easier than looking at a true surrogate. And this might be an interesting target for the trials. And again, I've been in the process now of designing a trial looking for the prevention of what appears to be a fairly particular painful setting in prostate cancer patients, with a drug that based on preclinical models, might actually work. The challenge now is how to design the trial. Next slide. So again, this is just a interesting article that I accidentally came across, where they're looking to apply artificial intelligence and machine learning in terms of studying cancer pain and pain management. I certainly did not go through it, but just what they're essentially doing in terms of using the AI and machine learning is categorization, biomarkers of classification, risk stratification, and management decisions. By no means is this final, but I think it would be interesting to read because this may help us in terms of developing ways to improve patient outcomes. Thank you.
Great, thank you, Dr. Scher. It's great to hear the perspective from someone outside of the pain field, really thinking about how we can apply these ideas from cancer to pain. We're now going to hear from Dr. Jackson Brewer, who is Chief Scientific Officer at Dolomics. Thanks, Jackson.
Yeah, thank you, Vivian. Thank you to all of the organizers as well for inviting us today to share some of our share some of the information that we like to share with external parties. You know, Peter, Susan, and Howard just did a really excellent job giving a background on both the kind of diagnostic and predictive biomarkers and everything in between, as well as the patient journeys before that. And so rather than diving a little bit further deep into the science that we do here at Dolomics, I thought it would be useful, given the context of this conversation, to talk about how we present the science that we do, which is very aligned with what the folks just explained before us, but to external parties as a way to try to enable translation clinically through different funding mechanisms, primarily through venture capital funding mechanisms, and how we try to explain this and really emphasize the importance of clinical biomarkers. So we'd like to get right out ahead of this. Something that we hear quite often is that pain is hard. And I think this is something that needs to be part of our discussion here today, is that to those outside of conversations like these, pain is still seen really as this monolithic structure with a lot of ambiguity. And there's not really, prior to the development of some of these biomarkers, a means or an avenue for starting to tackle or to address these things. We know, and we like to speak about the fact that the patient biomarker market is growing, particularly across neuroscience indications. A lot of the focus here today, though not all of it, obviously, has been on more molecular biomarkers. We similarly rely quite strongly on a omics background, as well as a few other functional biomarkers, to really identify molecular mechanisms of pain chronification and also to develop predictive biomarkers for treatments that we're working on. But we can see that even when we look at this exploding market, a relatively small percentage of it is actually allocated toward what would be considered methods for detecting these more molecular mechanisms, rather than either mobile-based applications, so things like pain journals for individuals, or wearables, so smartwatches and things like that that can pick up various different diagnostic markers for pain patients. So a little bit of a background on Dolomics before I really start to dive in a little bit more. Dolomics has built out a target discovery platform, which we've really used to catalyze our actual R&D efforts. So we have a bespoke pipeline that consists of a few biologics and a few small molecules as well. And we're using these to develop what we consider to be precision therapeutics for the treatment of pain. Now, again, I wanted everybody today to really put on their venture capitalist hat when you're looking at this and try to understand this from a different perspective than you normally would. What we tried to explain to folks is that it's really we see the chronification and the persistence of pain across different diseases as being a component of these cell-to-cell interactions in the periphery between nerve fiber endings in the various tissues that they're innervating, in the other immune cells or fibroblasts or what have you that make up those other tissues, and the signals that go on between those. And really what we're trying to sell potential investors on is that if these distinct and discrete molecular mechanisms that contribute to the chronification of pain that we can then target to provide patient relief exist and are actually the drivers of pain, as I think some of the folks who spoke before me would emphasize, then it should also be possible to detect very disease-specific biomarkers for these specific patient populations. So elevation of a given factor that leads to the persistence or chronification of pain in a patient population should in most cases be detectable through those different types of biosamples that we've already spoken about, whether it's blood or serum or even things like stool samples. We take a means of in silico target discovery here at Dolomics. Really what we're trying to do is to predict or infer those ligand receptor interactions that are ongoing, and then to model the downstream consequences of those through an omics approach to really output a list of targets for us to validate in our wet lab. All of this really begins through access to human tissue. So we're primarily working with dorsal root ganglion and spinal cord through various different partnerships with organ procurement organizations. But we're validating these targets that our platform is nominating in different multifunctional measures. So we're again relying on some of that multi-omic work, but we're also doing things like more traditional electrophysiology through plate-based microelectrode array systems, or ex vivo tissue imaging. So we can kind of give an illustrative example that again speaks to the variability across donors, as well as highlights the need, I believe, for actually identifying biomarkers. So our team is quite well equipped to take these tissues that we're receiving, to dissociate them and to generate them into organoids, which we can then plate on a microelectrode array. We can culture these over a number of days and record their activity. And while this is just purely illustrative and not from one of our actual therapeutic programs, what we know is that in different instances, donors will respond differently to the same insult or stimuli, right? And I think this really speaks to the fact that these donors all represent a heterogeneous population, as humans do. Things like drug abuse or socioeconomic status or BMI, their medical or surgical history, their age, their sex, their cause of death, among a variety of other factors, all begin to contribute to the variability that we see in trying to validate novel therapeutic targets for novel drug discovery efforts to take place. And really, it's this variability that we need to better understand. And I think that we can better understand this by continuing the work of assessing patient donor tissues in our laboratory, building out these multifunctional assays, and really starting to layer in all of the metadata alongside the omic data and the functional responses that we're seeing to identify biomarkers. One, to understand that more diagnostic component of what is actually driving pain, what stimuli are patients responding to, but then two, ideally down the road to start to develop better predictive biomarkers as well. So maybe a little bit of a perspective that I'll end off on here is where we see ourselves at Dolomics. So our scientists are very well equipped and have generated various biologics, which we think will be efficacious at providing therapeutic relief in different percentages of the population, rather than a broad spectrum analgesic, like a sodium channel inhibitor. Instead, we think that these should be targeted toward patients who have elevations in a given predictive biomarker. What we often see on the venture capital side is, as it relates to biomarkers, that there's a question of why. The money is simply in the therapeutic, focus on creating better biologics, more efficacious biologics, and the diagnostic biomarker will fall by the wayside. Similarly, when we prospectively look toward interacting with different insurance companies or regulators, often what we are told through different consulting efforts is, again, that if a therapeutic isn't going to work, we will simply stop giving it to a patient. There's no need to apply a prospective biomarker test to identify the correct patient population. And to leave off, really, in addition to giving any fodder for conversation in the open session later, I think the why here can simply be answered by we can reduce patient suffering by developing both diagnostic and predictive biomarkers for the therapeutics that we're creating as a means of delivering patient relief faster. Ultimately, it's about meeting patients where they are and not having to have them come searching for us. So that's really where I'd leave it today. And thank you all very much.
Thank you so much, Jackson. And so our final speaker for today is Dr. Sean Mackey, who is the Redlich Professor of Anesthesiology, Perioperative and Pain Medicine and the Chief of Division of Pain Medicine and the Director of the Stanford Systems Neuroscience and Pain Lab at the Stanford University School of Medicine. Thank you, Dr. Mackey, for joining us and being part of our committee.
Thank you, Yenisel and Viv. It's great to be here with all of you. Just doing a quick sound and video check, and slides all up and okay? Perfect. Welcome, everyone. It's great to be, I think, the last speaker before what I hope is a very engaging discussion session here. I'm Sean Mackey, and I'm a physician scientist at Stanford University. I focus on two major areas related to pain. One is in human neurosciences with a bit of a focus on neuroimaging, which I'll touch on very briefly. The other is the capture of high quality real world data and putting that data to use for both the clinical environment, but also to gain insights into the patient experience and learn from that. And that's guiding the objectives of my talk today. I'm going to talk just very briefly on neuroimaging biomarkers of pain, and I'll mention why briefly. And then I'm going to pivot and spend most of my time discussing non-biologic predictors of pain and how to pull all that together. So I've been doing neuroimaging of pain for over 20 years now, and you might think I'm going to spend the whole 10 minutes on it, and indeed, I am not. I think that at this point, those in the know recognize that the most robust data that we have around pain-based biomarkers is coming from the neuroimaging field. I think they've had a head start on this. Decades of experience in understanding pain-related regions and pain-related networks. And I have to compliment Tor Wager on the call for by far doing the best quality work in this space, and the rest of us are contributing. We've been able to use this information to build diagnostic biomarkers, moving towards prognostic biomarkers, some of that through the NIH MAP pelvic pain network, as well as others, moving into predictive and getting more and more into understanding treatment responses. The pathway is pretty clear for neuroimaging using MR technologies, PET, and others, but we do need to develop better ways of standardization and validation across large and diverse patient populations, and we need to integrate in other biomarkers into these neuroimaging models, and I'll touch base on that as I close out. But I think more importantly, we also need to translate this technique, this methodology, into something that will be useful in the real world. I do have concerns about the costs of MR approaches as well as PET approaches, and I'm hoping that we'll be able to get there using more ecologically valid and practical approaches like, for instance, high-density EEG or ambulatory EEG or FNIRS. We and others are working on that. I also, in listening to the other speakers, want to try to fill in what I think are perhaps some gaps and discussion points. And one of those has to do with the ethical considerations of biomarkers. And this is a paper that Tor, Karen Davis and a group published just a few years before the NIH working group. And we focused on applications of biomarkers here, brain-based biomarkers, but we had great concerns and still do about the ethical considerations and possible misuses for biomarkers. And we always have to keep this in mind as we're developing these technologies and putting them out there. I mentioned I'm only going to speak briefly on imaging. So I want to pivot and spend most of my time talking about non-biomarker predictors of pain. And the reason for that is I think it represents a gap, an unmet need or an opportunity for us as our group moves forward. Now, the original consensus statement that came out, this consensus group, where I have to credit Marianne Pelamonter, who's with the NIH and her group, who brought us all together. And Tor, Chris Veasley were on that committee. We brought many others. And we focused in that on traditional biomarkers and clinical endpoints, and the focus was on objective biomarkers. We followed the NIH FDA BEST playbook to the letter. But in a way, this somewhat precluded the discussion and integration of non-biomarker predictors into that model. And I think it presents an opportunity to integrate in other high-quality data into the modeling. Now, what do I mean by non-biomarker predictors of pain? These are typically non-biologic measures. They may be objective, they may be subjective. They include things such as demographic predictors, age, sex, ethnicity, socioeconomic status, behavioral and lifestyle predictors like sleep quality, physical activity, smoking status. And then we get into the psychosocial factors, social support, work-related factors, and then the big one, psychological predictors. Anxiety, depression, self-efficacy, probably the biggest predictor that we have ever found when it comes to amplification of pain, persistence of pain, treatment responsiveness, pain catastrophizing, this abnormal cognitive, emotional, evaluative process that has direct brain-related network links. And we typically capture these psychosocial and other variables through patient-reported outcomes, PROs, or patient-reported outcome measures, PROMs. Now, the thing is that when the last set of NOFOs that came out from the NIH on the biomarker development, we were told not to use subjective patient-reported outcome measures in our model building. And I have a HEAL biomarker grant on high-impact chronic pain. We're getting some really cool results with some of the patient-reported outcome aspects of it, but we were told to keep it to the objective. And I understand why. I've talked with the NIH and others. There are real concerns about using patient-reported outcomes in these models. One being subjectivity and biasing that make these models less reliable, and I get that. But while these PROs are subjective, they offer critical predictive insights into the future states of health and treatment outcomes. Therefore, they have high clinical value. They can help identify patients who are at risk of worsening symptoms and guide effective treatment choices. And these validated PRO instruments have been designed to minimize the variance and capture consistent patterns in these patients. Standardization and reproducibility have been another concern. And I get that as well. But, we have fortunately got these patient-reported outcomes like the NIH PROMIS measures that have been validated across huge populations and are psychometrically valid. More importantly, these measures are incredibly easy to capture in a clinical environment. We do this at Stanford and others do it as well. And they have high ecologic validity and practicality. They don't often align with mechanistic models is another concern that I typically hear. They're skeptical of these PROs because they don't have direct ties to the biologic mechanisms. And it's true. But while they may not directly measure a biologic process, they do reveal patterns in the patient experience that often align with the biomarker findings. I get what NIMH has been pushing towards to perhaps move away from DSM into more of the RDoC, into more of a biologic mechanistic based classification of psychiatric conditions. I think that in pain, we should not take that full move and we need to better balance. I'm going to come back to that word, the patient experience and the mechanisms. I did put the data integration challenges. I think that's less of an issue with more contemporary machine learning approaches and otherwise. I think we've cracked that problem. Lastly, I think there's potential for misinterpretation or overemphasis on the patient experience. And I think there's a truism to that as well, which is once again why I think we ultimately need to balance these non-biomarker-based measures with the more traditional objective biomarkers. Let me give you one example of this just to illustrate the point. So this was a study I did a few years ago, using our patient-reported outcomes data at Stanford Choir. It's a learning healthcare system. It's an open source model. We give it away for free. We used about 11,000 of our patients that we deeply characterized. We built a clustering model using hierarchical agglomerative clustering, which is a fancy word for we built trees with clusters. And we found that the majority of these non-pain related clusters were due to symptoms of depression, anxiety, anger, sleep impairment, and fatigue. And they could highly predict pain severity and pain impact. Highly predict, not only in the now, but they could predict a future state. And so even if you don't buy the PROs for the now, the fact that they can predict how a patient is going to do in the future is incredibly powerful, and they are trivial. They're really easy to get. So let me close out and just augment a little bit with what has been said before to drive home the points of our first two speakers with real world experience. Pain is really complicated. As a physician who cares for people, and I know other people in the group here as well, it's really challenging. This is just a simple breakdown. We have over 200 medications now for pain. We have over 200 procedural interventions, scores of mind-body treatments, huge number of physical exam findings and physical therapy treatments. And we've got to all keep this straight in our head as clinicians. And it's darn near impossible to keep it all straight. And it's clear there's not going to be one biomarker that gets us there, which is part of my closing statement. One of the key messages that came out of our consensus statement was we need to have multimodal biomarkers. It's ultimately the integration of many of these biomarkers and ideally non-biomarker related predictors that's going to help us to reach that holy grail of precision pain management. So with that, Viv and Yenisel and everyone, thank you for allowing me the opportunity to spend a few minutes, and I look forward to the discussion. Back to you.
Wonderful. Thank you, Sean. I think you really really nicely covered a lot of the questions in the chat on whether psychological factors are considered biomarkers. So we sort of started with the definition from the best NIH definitions, but then sort of circled back to the fact that non-biomarkers or non-biomarkers by definition are still important. So actually, I just want to sort of start that with the Q&A. We'll do about 15 minutes of Q&A, take a break, and then we'll come back for a more full discussion after the break at 3 o'clock Eastern, which is noon Pacific time. So Dr. Cruz-Almeida, if I can just ask you to comment a little bit from your experience on how to integrate psychological factors, which may be not officially considered biomarkers, but how we can integrate these when we think about development of biomarkers or as endpoints in chronic pain.
Yeah, so definitely, I mean, I think from the definitions, right, that include biomarkers, and this is to answer one of the questions, I guess specifically, which Sean has really done a wonderful job here, but, you know, this idea of measurable biological indicators of normal or pathological processes or responses to interventions by definition precludes sort of psychological factors. However, we do know how important psychological factors, as you know, Sean was saying too, that they can be sometimes very easy to measure clinically, their role in the experience of pain. And I think that's where, you know, in the field of pain, this idea that Sean just proposed and really put out there of the you know, we have the typical biomarkers, but then also the predictors, right? Non-biomarker predictors. And I think we all know that psychological characteristics are really important in the pain experience. So I'll put Sean on the spot to, if he wants to further.
I think you covered it, and I'm glad that it's coming up in the Q&A session in the chat. Yeah, it's an incredible opportunity to capture this high quality data. I mean, where we'll ultimately go is we're going to tie these PROs, you know, whether it be pain catastrophizing or anxiety or depression, we're going to be able to tie them to a direct neurobiologic biomarker. But we're not there yet. So why not use the quality data that we have now while we're better developing our mechanistic understanding of how pain catastrophizing and self-efficacy works. And by the way, even if we get the mechanisms, we still need an MR at $500 and some odd an hour, plus postdocs to analyze the data just to be able to put that to use. Why not take advantage of something that's free and easy? Let me be clear when I say easy, because I'm respectful of our patients who take the time to fill out that information. I get that. But it's reasonably easy.
Yeah, and our colleagues too, like, you know, the lot of the psychologists that have worked on developing a lot of the psychological constructs that have shown to be, again, really important in the pain experience and multidimensional experience of pain.
Thank you. I'm actually, Chris Beasley, if I could bring you into the conversation. There's one quote from the last biomarkers paper that came out that basically said that pain as defined by an individual is their ground truth, meaning that that patient report is really, in the end, what matters because it is an individual experience. So how do you imagine sort of integrating some of these ideas of like, well, it's not officially a biomarker. How do we validate biomarkers up against some sort of gold standard, which ultimately may be subjectivity from a patient?
Could you clarify a little bit more about what your question is? How do we, I understand what you're saying, but what is your specific question?
I guess I'm just wondering from your perspective, how do we address the need to involve the patient report with the balance of, you know, each patient may report something different, may experience something different, because ultimately the self-report is subjective. So
Right.
Yeah.
Interestingly, I just came back from a meeting last week, the Pain Therapeutic Summit, where there was this whole panel on biomarkers that was led by the NIH, and industry was participating in this as well. And a lot of the biomarkers that were being developed by industry were tied back to patient-reported outcomes, right? So that biomarker, the holy grail, or right, the goal here is to identify an objective biomarker, but every objective biomarker that they were developing was identified by tying it back to a patient-reported outcome, whether that's pain, severity, intensity, so on and so forth. So, I mean, you know, I have to agree with what Sean is saying. I mean, I understand the goal of trying to find the painometer or the objective biomarkers. And obviously we need to advance science in that direction for various reasons. But ultimately, you know, as he brought up as well, there's ethics of a lot of that. There's cost issues there. And ultimately, most of those will try to be tied back to something that could have clinical, utility in the clinic's office, right? Which can't be expensive, and it can't be timely, and and it has to be patient friendly and clinician friendly. So I think I think we need to take what we know from research that's been done on objective biomarkers, as well as predictors, as Sean talked about, as well as patient-reported outcomes, and use what best available science we have right now to guide us in terms of clinical practice, as well as where we go next as a field. I mean, one of the major questions that I brought up in our first meeting was, and we had this discussion at this meeting last week with the NIH staff as well, is has pain science advanced far enough yet at this point in time to enable the elucidation of objective biomarkers in pain? Or is it not there yet, right? And I think that remains a major question.
This reminds me of a situation we have in our world of the prostate cancer. And if you think about what phase 3 trials typically look at, they're looking for time to event endpoints. And most of the time people will say, you know, in order to say that something prolongs survival, X number of patients have to die. So we ran into that, and it was I would say a real problem. So what we've done now in the prostate world, we've looked at patients who we know with disease that is incurable with any single treatment, and we're using an endpoint elimination of all disease. And I'm not familiar with Dr. Mackey's work, but I can tell you I'm very interested in it. because in the prostate world, we periodically get together and say, how do we change the field and how do we change your approach? If you have if a patient, we have the same issue with patient-reported outcomes in our trials, and prostate cancer is a disease that commonly goes to bone, and that can hurt quite a bit. If you eliminate the concept that if a patient tells you they hurt, it's real, and if you use as your endpoint of a trial that you've eliminated it all, there's not going to be a whole lot of argument, and that's something I would like to talk to. I can call you Dr. Mackey or Sean a little bit further, because I think we can test that concept in the trials, because we have a consortium that was sponsored by the Prostate Cancer Foundation and the Department of Defense, where we are, basically it was to enable our collaboration, and we can test that really quickly because we have over 100 sites that are together. And if you have an interest in validating what your work, I would really be pleased and honored to do it.
Great. Setting up collaborations in real time.
There you go.
I think
I shop for
Christine,
technologies looking for things that'll help people. No one's going to argue if it all went away.
that is definitely true.
That's it.
Christine von Reisfeld, I think you had a comment on this, and then I'm going to go a little basic science after that.
Sure. I just wanted to touch on the patient-reported outcomes. I think in order for patients to truly report patient-reported outcomes, right, we also have to be trained. What is it that we should be reporting? How should we report them, right? When we're looking at these things, how do we get people to actually convey the messages that they're trying to, and really train them on those outcomes and what could matter? Because I did that as well, right? I collected lots of things that probably didn't mean anything. But then after working with my own physicians and knowing what the things were that I should be reporting and when I should be doing them was also very helpful. So I think when we're talking about these PROs, to really look at how do we educate patients into getting us those reported outcomes and a clinical grade outcome that we can use.
Do you want to join the party?
Yeah,
I would love to.
That's a really
I'm serious. No, seriously, because that would be really important, and that's something that should be included when we offer a treatment to somebody, because this way you'll understand you're looking at something that's meaningful, where there's no argument that if it gets better, it's good.
Yeah. And I'll make one comment. Can I make one more comment? Really?
Please go ahead. Yes.
I was on a medication for a long time. I have severe neuropathy in my hands and feet. I was not feeling anything. My doctor gave me a medication that then caused extreme pain. If I did not have a good relationship with my doctor and understanding that that pain coming back meant that I was actually feeling again, I may have cut that medication and just walked away. And so I think it's important to have that communication, the expectations of what is supposed to happen, when it's supposed to happen, and when it doesn't, how do we have those conversations?
Yeah, I think that's a great point, is aligning the language and the reporting and expectation setting. I want to come back to one thing that Chris Beasley mentioned and direct the question towards Peter Grace, which is about what is the state of the science? And this came also from a question in the chat about an ARPA-H catalyst initiative, speaking about drug development and how we get FDA approval for drugs, and really thinking about, novel ways to develop new, maybe not new data sources, but using existing data with AI/ML. And then the question is, what is really the validity of these preclinical rodent models for pain and pain therapeutic development?
Yeah, so I mean, mice and humans are obviously not the same, but the many mechanisms are evolutionarily conserved. And so I think rodent models have been very good tools to identify and understand pain mechanisms, and some of these have been validated in humans. And so it's this information then that is used to build these computational tools that could then be used to predict new therapeutic approaches. For drug testing, we also see some signs of predictive validity there, where drugs that we already know are effective in treating pain in patients, then when we take them back into animal models, they also relieve pain in those models as well. It's going the other direction where we don't always have good predictive validity. And so I think that in preclinical drug development, we don't, the wins and losses are not really very well prospectively identified. But to bring it back, I think, to biomarkers, I think this is where they can really help us move forward. Because I think we could enrich study populations for the mechanisms that are being targeted by a particular intervention. But then I think also by using them in preclinical studies and using them as translational tools, we can determine whether the disease process has been modified by that intervention or not. And I think that's an insight that we don't have now, and I think could really help us understand when we have a failure, for example, why was that the case? And was it because that drug then failed to modify that same disease process in a human? So I think biomarkers can really help us move forward and improve the predictive validity of our preclinical models.
Great, thank you, Dr. Grace. So I think given the time, I'm going to thank all of our speakers, and then I think we'll move to our break as scheduled now. And then please join us in just 15 minutes and we'll be back to continue the conversation. In the meantime, while you're taking a few minutes, if you have questions, please put them in the Q&A. It's the easiest place for us to track the questions. If there's sort of engagement or chatter that people want to engage with, that's great. Please use the chat function for that. And we will plan to be back here in just 15 minutes to continue the conversation and bring in some of our other subcommittee members, as well as some of the others who presented earlier. So thank you so much for your engagement, and we'll see you very, very soon.
Yesenia, I threw in a comment about our AI rights that we had written, just in case anyone wanted to take a look at it as well.
Yeah, and we have a few more questions on the Q&A, but for our participants, again, it's easier for us to see the questions if you put them in the Q&A versus the chat, but feel free to use the chat to make comments and things like that. So yeah, I see that, Kristen, thank you.
I don't think I'm doing so hot with the chat because I don't know if anything is getting received.
I'm trying to see if I see anything.
It just seems to sit there.
And all right, 3 o'clock. And that was not me in the chat. I didn't put that in, but we can. Okay, and so actually, let me take a moment to introduce you to two of our subcommittee members that did not give presentations today, but I would like to have Dr. Tor Wager to introduce himself, and if you have, as a both previous and current subcommittee of the HEAL initiative, and I would like to ask you for sort of initial thoughts at this point that you may want to provide on the conversation that we've been having, and then Dr. Fields, I will ask you to do the same.
Wonderful. Hey, thank you. Thanks, everybody. And it's really, really nice to be here, Yenisel and everybody. And there were just a fabulous set of presentations. I have a few thoughts that'll just take a couple minutes, if I may. One is that we've heard a lot about the idea that we need biological indicators of mechanisms that drive pain in various ways. I think that's really important. That has a couple functions. That makes those real for patients and for people who are developing and using treatments. That may not be that important with cancer because everyone knows that cancer is real, but not everybody knows that pain is real in a patient, and that fatigue is real, and that depression is real in some sense. And the other reason, as we've kind of covered, is that we need those as biological targets for treatment. So I think that's coming through very strongly. And I think one of the reasons is that there's a disconnect between measures that we all think of as unequivocal goods, better feeling, function, and survival, right, on the FDA approval pathway. But these have complex determinants. So people know that they're in pain, but they can't tell you why at a mechanistic level they're in pain. And so I think part of the biomarker process is discovering treatable biological causes. And I'd like to just say like a couple of things beyond that then to follow on. And, I think we've heard about molecular biomarkers. Those are really important. They're basically treatable targets, single, proteins, for example. But there are also systems level biomarkers. I think about neuroimaging and brain measures that are, there might be multiple different brain pathways that lead to pain. But if we have a biomarker that tracks pain now, then we might reach that different ways, and that's going to give us an idea about whether multiple kinds of treatment are working, right? That could be a psychological treatment that we otherwise couldn't really validate. That could be a neurostimulation treatment. And I know Sean Mackey is a leader in this area, developing, TMS-based treatments for pain and testing those. It could be a drug target as well. And it's precisely because people's pain reports are very complex in terms of the context that drives them, right? That's going to be different in one context with another, from one culture to another, with one clinician versus another. And so that's why we need these things that we can sort of standardize and that are mechanistic targets. So that's one point that I wanted to make. And a second point is I think that we need biomarkers for things that go beyond pain now, because the patient's experiences and their function are about so much more. So I'm thinking more about fatigue and mood and what confers good function in spite of level of pain X. Right? Why do some people perform better and are able to, and other people are sort of really distracted or unable to function? So those are new directions. And the final point that I wanted to make was that I think that it's really helpful to think about biomarkers at the trial level rather than only at the patient level. So there's been a lot of discussion about testing biomarkers in individual patients to discover disease mechanisms and their therapeutics. But some of these techniques are really expensive and they're not going to get that much cheaper. Like fMRI is expensive, proteomics is expensive, and single-cell RNA-seq is expensive, et cetera. So one idea is that we often can develop biomarkers that we can use in a clinical trial to define, identify, and validate a target. And then we don't need the biomarker in every patient. Then we can take that and use that clinically. So that could, of course, be a protein, right? You discover it in a trial, you can target it, and then you can apply it. And another example is in the brain, with brain stimulation and neuromodulation. You can identify a target in a trial, and there's lots of questions about what are these targets? What are the right pathways? How do we optimize that stimulation or that intervention? And then once we have that, then we can deploy it in a population. And it's always going to be better if we can personalize it based on personalized biomarkers and targets. But nonetheless, we can get a long way just by using those biomarkers at the trial level. So those are a few thoughts, and just really a wonderful discussion.
What biomarkers would you nominate?
In terms of brain pathways, or in
No,
terms
brain is, I think, at least it's one area that's pretty consistent. But a patient who has cancer in different parts of the body, you can't say it's going to. I mean, I'd probably start with the brain because it's one place. But what would you say now is the first one you look for?
Well, okay, so
or how do you decide that, you have to have some, if you're doing a clinical trial, you have to have some criteria.
Yeah, so in the brain, I don't know if this will be helpful for you or not, but in the brain, I think of classes of pathways and patterns that track pain now. And so that really is about nociceptive pain. It's that there's something driving it from the body. But on top of that, there are pathways that are related to a fear and avoidance, and those become entangled with pain. So there's nothing happening in the body that's causing the pain. It's really, it's about the central nervous system itself. And so then there's a different class of therapeutics, right? So then for that kind of person, psychotherapy would be very helpful. Surgery or a peripheral intervention will not be as helpful. So that's kind of a flavor, but I don't know if you're thinking of, you'd like something more specific or what you're.
No, I'm just thinking of designing the trial to prove you're right. That's what I'm thinking of. So, I mean, we should talk later because I think that this is the type of thing that we can do some exploratory testing on and see if we can start identifying what are the characteristics of people, looking at some of Dr. Ward's components as well. And maybe we can create something that's a meaningful set of eligibility criteria that you can show that there's been an improvement, and turn it into a regulatory approval, which is really what your goal is here. And also decide who is the patient who would benefit from that particular approach.
Yep. Yeah, absolutely. Just super quick follow-up on that, really quick. I mean, yeah, multiple ways to do that. One way is to identify a candidate biomarker, recruit people who are high and low in that biomarker, and randomize them to a treatment that's matched or not unmatched, right?
No, that's great. Just figure out what be specific.
Yeah.
So let's also hear from Dr. Aaron Fields, who's faculty in the Department of Orthopedic Surgery at University of California, San Francisco. Since we haven't heard from him yet in the panel, and if to give us a few thoughts and sort of at this point.
Sure, thanks, Yenisel, and I really enjoyed hearing all the presentations this morning. Those were great. I learned a lot. I think one aspect that I think deserves mentioning is the need for objective biomarkers of an individual patient's pain mechanism. So whether it's nociceptive or neuropathic or nociplastic, or perhaps it's a mixed pain mechanism, and the need to understand the mechanism in order to better target the source of the pain if you know, you're talking about a therapeutic biomarker. And I think that's one area where we're certainly struggling is how do you identify biomarkers of pain mechanism. That's one area where I'm curious to hear from the other panelists what approaches they've been taking, and how do you design studies that account for pain mechanism when developing new biomarkers. I think another area where I guess I just really enjoyed hearing Susan's comments is about the challenges with these deep phenotyping studies and the need to balance, you know, the large sample sizes that are required, but also, you know, the potential opportunities to use these N of 1. She described it better than I did, but N of 1 studies that really get at the individual patient's level and identify, you know, what particular biomarker is relevant for a particular patient. So I'm not sure what the middle ground is there, because I know that on the one hand, whatever works for one patient may not work for another patient. So that's why you need the large sample size. But on the other hand, you know, we're working with a large cohort here at UCSF that's deep phenotyped, and working with that much data is really a challenge too. So I guess that's one of the other areas where I think there's an open for discussion is these strategies for managing large volumes of data, multi-omic data, and multi-domain data. So maybe I'll start with the first one. In terms of pain mechanism, you know, what are the current thoughts on biomarkers that are specific to individual pain mechanisms, nociceptive, nociplastic, mixed, et cetera?
You got to pick some that you want to test. So let's say you define a degree of patients with, let's say, a high degree of symptoms, and start there, and just try to see, you know, what would you pick to look for, and just do it like a phase 2.
How important is it to, in the design or development and validation of the biomarkers, though, to know that you're testing those biomarkers in a patient population that all has, for example, nociceptive pain or neuropathic pain or nociplastic pain?
Well, at some point, you're going to make a clinical decision as to what is manifest in the patient. It's not going to be perfect, but at least you've got to start somewhere, and you don't want to start with 1,000 patients.
Yeah, I think this is where phenotyping is so important, and one of the challenges we have in the pain world, because pain is not pain. So so I really, you know, even your point, Aaron, and I would love to hear others. There's no, you know, easy way to have consensus, and there's still, even those with nociplastic, for example, it's still a murky construct, right? And then again, we're looking at a lot of different variety of symptoms and signs that go into the phenotype that you would see in the patient population. And that's, I think, why in the pain world it's a little challenging at the moment. But Viv.
Yeah, I just wanted to bring a question from the Q&A from Benedict Alter, where he states, as a physician, patients come in with pain, so a biomarker of pain intensity is less clinically useful. What about therapeutic biomarkers? And I think, you know, Jackson spoke to this and maybe can speak to it again, which is, you know, how do we use therapeutic biomarkers not just to predict, you know, which treatment will work, which was very nicely highlighted by our patient partners, that it is a real roller coaster when your doctor sits down with you and just picks out of a list, and then you have to try it, and then you think it might help, and then it doesn't, back and forth. So maybe to find the right treatment, but also to phenotype patients who may be more likely to respond to a given treatment, because right now we don't know, and we have very heterogeneous patient populations coming to many different types of clinical trials. So Jackson, I don't know if you want to
Yeah,
comment a little on that.
I will happily chime in. I'll also predicate my answer on saying I'm certainly not an MD, so I won't pretend to play one here on the
Unbiased.
webinar. But what I would say, strategically, the way that I would think about this is it's really about following the patient journey all the way through therapeutic or drug development, and kind of layering those things on top of each other. So I mentioned that we took a multi-omic approach, like many of the other folks do, to actually, initially identify what we consider to be mechanisms, and then also on the predictive side as well. I would say in a perfect world, as we move our lead asset now through IND enablement and launch into clinical trials, I think it's just as important to be acquiring those biosamples all along the patient dosing journey or progression, so that for future patients, when a drug is hopefully FDA approved, when they go to their doctor, either they're able to be phenotypically categorized or at least monitored throughout the treatment, so we can get another idea as to whether the therapeutic is having an effect, not to replace the patient-reported outcomes, because I certainly agree with Benedict's point, right? A biomarker of pain intensity is almost meaningless when you can ask a patient how intense their pain is. But if we can understand, particularly with a biologic, for example, if it's going to have a longer time course to start having an effect, being able to gauge whether that effect is in motion or not, I think would certainly be clinically useful.
Could I follow up on that for just a second?
Yes, please. And then if I could also ask you to comment more on the omics and the integration of data after you respond to this one. Thanks, Susan.
I was just going to completely agree, and it's really been a fantastic discussion about objective versus non-objective biomarkers. And when I think about all the PROs and PROMs that we all collect, they're static measures. They're sort of at the given time, or we're asking a recall question, in the past week or the past month. And I haven't heard, I think, Sean, you mentioned it, and maybe one other person mentioned it, but something I haven't heard a lot about is momentary ecological assessments or real-time data collection using mobile apps or the web, where you get more diurnal, potentially more information about somebody over time. But then to Aaron's comment, that makes all of the data analysis that much more complicated, because now you have continuous variable level data, different times and different people across different spectrums. So I think this is a really important discussion. And then you wanted me to talk about the multi-omics and the data integration. My sense is, we have a great group of computational scientists at our College Park campus, and they have infrastructure that's capable of doing the types of analysis, but they're not pain scientists, right? So we have pain scientists who collected all these data, and they want to be able to integrate it and either predict a therapeutic response or predict chronification or other. And it's really going to take, I think, an interdisciplinary team of scientists to be able to come together, spend time together, learn about each other's field, technology, not to the point where they can use it themselves, but they can appreciate what the challenge is and what the possible solutions are. I think that would be important. And the other thing that I've heard that I think would be important in this realm, many of us have large existing sets of data and samples, to your point, Jackson, about, we collect, 3 tubes for every person for every time we see them, regardless of whether that was written in terms of a specific omics type. And there has to be a way for us all to leverage that. I'm sure we all have some common data elements that cross these studies. They're not going to be all the same or perfect, but I would like to think about and maybe discuss, are there ways and funding opportunities and mechanisms that could capitalize on some of what we already have in existence, and that would give us a lot more information to move into the future.
Yeah, and Susan, you just touched on, so one of the questions on the chat was how, you know, non-biomarker predictors can be highly correlated, predictive to pain, but the amount of data contained is really large. And, you know, you have tens or hundreds of thousands of data points, and, you know, is there a way to address this? And Troy in the question and answer was saying maybe expanding and including national surveys, epidemiological approaches that can be combined to in-clinic data collection, for example.
Yeah, no, I think that's very reasonable. And, you know, I also think other fields have talked about common data elements. And, you know, I think, are there things that we should all be measuring in a particular way at a particular time? To Christine's point, should we be training participants or training patients on how best to tackle this battery of pros and proms and maybe ecological assessments, so that we get the best information and they get the best information? And also, I guess the other question is iterative processing between the researchers, clinicians, and patients or participants. So here's what we found so far. How does this resonate with what you're feeling or what your experience is as a person with lived experience? And then that informs the next step of the research or the next step of the practice potentially.
You're right on target. Whatever we measure, we have to measure it consistently. So it may not be a particularly valid, you know, regulatory measurement, but if we do it the same way, and you have a group together, this is why, you know, talking about our consortium, we can do that and just see how it reports. And I still think if there's something present, a patient will mention it. And if you make it disappear, it's a binary endpoint that makes everybody happy. So why not? We got to start somewhere. And I think starting just making some agreement on how we're going to do it, and then just combine the information and see what happens. If we do 100 patients and it's all over the place, well, that whatever it is, it's not going to work. But if we, as long as we get some consistency, that's a starting point.
So I just want to shift to something somewhat related, which is, you know, the sometimes elephant in the room of pain research, which is the placebo effect. And I know, Dr. Wager, you commented on that, but maybe you can speak a little bit to the work that your group has done on placebo effect and how we sort of integrate or think about that when we're looking for biomarkers or even for therapeutic endpoints.
Yeah, thanks. I think, you know, there was a question about whether, you know, it's useful to develop biomarkers of placebo effects. I think that's one of the things that could be very useful, because that could be a marker or set of markers for things that predict a person's response to non-specific interventions, right? So if there's a treatment with potential harms or costs, like back surgery is my go-to example at the moment, then you know, if you knew that that person would respond to a placebo, it's less likely that the cost-benefit analysis would favor, you know, getting back surgery. So it's really a clue that there are other kinds of psychological mechanisms at play. And I think it's tricky. So I think there's, you know, I think there's a lot of commercial interest that I've seen in developing predictors of placebo response, mostly to screen out placebo responders. And one interesting point is that can sort of cut both ways, right? So if you try to screen out placebo responders, if the mechanisms of the placebo response and the therapeutic response are entangled in the brain, if they're similar, then you're actually screening out the real responders as well. And that there's evidence for that in pain, that the people who respond to an analgesic are also the people that respond to a placebo. And so if you know, you could be doing exactly the wrong thing. And on the other hand, under some circumstances, you know, that could be the right thing to do. So I think understanding predictors of placebo response is really important, and really how they overlap with active mechanisms of recovery from pain and pain relief. So it's 2 cents, and I'd love anybody to jump in and add to that.
Dr. Mackey, I don't know if from your imaging experience you wanted to add anything or.
Well, I think Tor covered it well. I think it's the point that's often not discussed is we talk about having a biomarker for placebo to screen them out, but as Tor correctly said, by doing so, we could be screening out the therapeutic responders as well if those mechanisms overlap. I think I'm sure Tor and I and others would agree there is value in having that biomarker because that would set a foundation upon which you could then study those placebo responders and identify, are they, to what extent are they therapeutic responders? Are the non-placebo responders therapeutic responders or not? It's about optimizing your clinical trial and then ultimately, enriching it, if you will, to maximize the therapeutic benefit.
Could I comment on that briefly on the placebo response? I'm also wondering for both of you, the question of mechanism of the mode of treatment could also impact, right? So for example, if it's a pill or if it's deep brain stimulation or if it's cognitive behavioral therapy, or I'm thinking about the trials now in the psychedelic space where there's a lot of touch and a lot of therapy that takes place prior to that, which one might expect. So how would we deal with biomarkers that are mechanistically invoked in each particular or subsets of types of interventions?
I think you bring up a great point, Susan, because I think one of the issues with pain is that it's highly susceptible to placebo effects over short timescales and sometimes over long timescales. And so when people get better in clinical trials with a therapeutic, you don't really know why. And that's one of the reasons that many pain trials, among other types of mental health conditions, have failed, right? Is because you think you're targeting the specific mechanism. When you get to the phase 3 trial, it fails because of the placebo response. And so along the biomarkers line, I think it's really important to have biomarkers that don't respond to placebo, but that do respond, that track pathophysiology that's linked to pain. So that's one of the things that we've really tried to do is develop biomarkers for pain in terms of fMRI patterns and brain systems. And what we find is that they track pain really well, but they don't respond to placebo effects much at all. And so that's an interesting target, right? So now you can think about taking that into a clinical trial where you look at that in a phase 2A, 2B trial as a marker of target engagement because it's not susceptible to the placebo response. So it's not replacing the clinical endpoint, but it's helping you make a stop-go decision. And I know, Sean knows this very well, right? But Irene Tracy, championed this idea for many years, along with David Borsuk and others.
Thank you. There is a question on the chat that I want to bring up, and that so one of the participants is asking an important topic or point that we haven't talked very much about today is the distinction between biomarkers of disease, so of particular disease versus biomarkers of pain. For example, in the osteoarthritis field, there's a clear disconnect between a patient's histopathological symptoms and the present severity of the pain. Developing effective biomarkers for pain will require separating biomarkers that predict the disease development and progression from those that would predict pain chronification. This may be linked for some, but definitely not all disorders. I would appreciate your insights on this. Who wants to jump on this one? I'm looking at Tor, Sean.
I don't know, Sean, go ahead.
I think they're right, and they're not mutually exclusive issues, but I think that the use case here was OA, right? And there hasn't been shown to be much correlation between severity of that and person's pain experience. And so identifying a biomarker for progression of OA may have no bearing at all on their progression of pain. Hence, I think, while again, not mutually exclusive, I think we're going to have to take them on a bit separately.
Yeah.
I don't know,
Yeah,
I invite other, disagreements, thoughts?
I mean, just maybe to add to that, I think, when it comes to diagnoses, there are 650,000 different combinations of symptoms that will earn you a diagnosis of PTSD. So there isn't one, so you can't have a biomarker for PTSD, and you can't have a biomarker for depression. And Kathleen pointed out in the chat, I believe, that there's probably many kinds of nociplastic pain. There's maybe 100 different, who knows how many different mechanisms there are. And so ultimately, I think trying to look for fixed biomarkers for those categories isn't, it's going to be limited. But the hope is that we can disaggregate those. So we haven't talked too much about biotypes, so the dream would be, okay, we can identify in terms of brain pathways, multiple pathways that all converge on the same ultimate, symptom phenotype, and then we treat you based on that biotype. This has been explored in depression. I mean, it's one of the sort of big ideas, and there aren't very many definitive answers yet. But I think maybe there's more in cancer. There's probably much more success, right, in terms of molecular biotypes of cancer, and then you treat those. But maybe Howard, you can speak to that.
No, it's different. The question is, where do you start this process? You got to start somewhere. And we know that nothing is perfect, but we have to build it up, bottom up.
So maybe along the lines, there's a comment from Lucas Rodriguez about, in the cancer field, using like a drug that maybe is for ER positive breast cancer specifically, could we imagine a future where we say, oh, well, you have, XYZ positive diabetic neuropathy, and therefore we'll treat with an XYZ targeted drug. So maybe this is like, the mechanism-based therapy that a lot of people have been talking about.
Great.
Yeah, it would be great. I mean, I think on the preclinical side, that is something that we have the opportunity to do, as Peter mentioned, with our preclinical models, and really using them to investigate, single molecules or groups of molecules, using omics data, and then aligning that with human studies and seeing how translationally viable some of these targets are. I think that's something that's really important, because it is a continuum. And I know there were some comments about, well, are we over preclinical models? Is there a point of using them anymore? And I think there is still validity and reason to use preclinical models, perhaps mostly because they're so controllable, have
Right.
Homogeneity of those models and of the subjects of those models. And we also have a lot of genetic manipulations that we can do, in particular in mouse models. So I do think there's added value to them, but we're definitely not there yet in terms of, a specific positive receptor being a treatment target. So there's a lot of different ways to go about it. So yeah, Dr. Sluka, please go ahead from there. Oh, and I'm sorry, just unmute yourself if you would.
I was just thinking when you were talking, Vivianne, that and we were talking about separating out of the disease biomarker from the pain biomarker. Sean says we have to do them parallel, but actually we can use the animal models to take them back and find out whether or not that biomarker was really related to pain, or whether it was related to the disease progression of some sort. And I think that's one of the greatest values, is using them in concert with human studies to validate ultimately what you're testing is really related to what you think it is.
Yeah, I think I made up a term I call it clinically informed basic science, which is that idea of like looking at what the clinical findings are, but then being able to test it for causation in mouse models. You really, most of the time, can't do in human studies, because you can't knock out a gene or add back a gene or gain of function, things like that, that we can do with our animal models.
That's a great term.
Viv and Kathleen, you haven't mentions, but I've been rather impressed on the preclinical models with how the field has moved forward. It's come under a lot of criticism over a long period of time about reflex measures, but you all have like created these really cool behavioral, rodent models that, seem to be more and more mimicking the human pain experience. So it seems
Yeah,
like there's
Dr.
still,
Rice, do you want to? I love that you brought that up, Sean. Peter, do you want to comment a little bit on some of the newer measures of pain in rodents?
Yeah, I mean, I think that relates to my comment about the issue with preclinical studies is that we don't measure the same things that we measure in humans, and that could be one of the reasons for the disconnect in translation. And so, as you're all alluding to, we've relied on reflex measures, which ironically are very close to the QST that Susan described. But some of the other issues that as humans we experience are ongoing pain sensations, which we've been able to model using operant conditioning and things like that. I think the other, maybe we're swaying off topic here from biomarkers, but I think the other sort of important thing is that we're able to, recognizing some of the weaknesses about preclinical models, we're able to then supplement them. And so I think being able to access human tissue samples now as well allows us to go back and forth and make sure that our target in a preclinical study really is valid in human samples, but then take it back, as everyone's been talking about. If we identify something in a human sample, then take it back and test it for causality in a mouse model.
Can I just
Can I ask a follow? Oh, sorry.
I don't know who to call in first, but Tor, was yours a follow-up or was it?
I think so. Sure. Okay. Yeah.
Okay, we'll start with you and then we'll go to Susan. Thank you.
All right. Thanks. So I just think that in some ways the non-human research field has partially leapfrogged us in this way, because I think people are using these like deep lab cut and these measures of pain behavior, machine learning driven. And I think that's spreading a lot. And I think we need that more in human research to look at observed behaviors and be able to quantify them. And so then if you can line up the behaviors in parallel, if it's musculoskeletal pain, let's say, you can have parallel behaviors. And then you can do what you did, Peter, and show the Venn diagram of the overlap in, dorsal root ganglia, markers, right? And then find those. And then that's likely to give you a subset of things that's more amenable to translation. So that's exciting to me.
Thanks. Susan, do you want to go ahead?
Yes, I just wanted to, I guess, ask Peter a question. There's been probably debate on this over the years. Do you see a role for larger animal models, for example, swine or non-human primates and some of the biomarker work? And is there a place for that model, either driving back from clinical findings as a stopgap prior to getting to rodents or going the other way?
I probably see it going the other way. And I think actually in my mind, the huge advantage of larger animal models is that then we could tap into natural disease models. Because in our rodents, we can't do that as well. We experimentally induce them, which has a number of shortcomings. Whereas I think if we could go into swine or in horses, where we have sort of natural models, I think that's a good intermediate step.
Can I actually add? So we have now started working on a project that's HEAL funded, where we're doing studying basically osteoarthritic horses for that same reason. And we're actually moving using our QST and protocols that we do in human in the horse and as a clinical population. And I think it's really exciting, and actually doing, Tor, what you were saying, that's our plan. We're going to compare not only QST, but also a lot of the biomechanics and gait patterns, and from both human and that horses. And I think that will be, we hope it's useful.
So I just had one comment and one question, and that was to follow up on some of Tor's statements as well as Sean's. and give the patient perspective on the multidimensional impact and approach of chronic pain, about it, the importance of, as Tor mentioned, sleep, mood, cognitive dysfunction, fatigue, and the idea that, as we were just discussing with, peripheral states of pathology, right? Somebody may, we've shown this in many different disease states, you may have very severe endometriotic lesions, but have very little pain, and you may have very minimal endo lesions and have an extraordinary amount of pain, right? So these biomarkers for the disease process versus pain are different, as Sean mentioned. So you think about, well, what are the biomarkers for the amplification of the pain state? And one of those, when you think about a multidimensional approach, like Tor said, we know the bidirectional approach of sleep, impact of sleep on pain, of mood on pain, and vice versa. So when you think about just trying to tie this together with what patients say, is that they get so frustrated with just somebody asking them how bad is their pain on a scale of 0 to 10 when it impacts so many other areas of their life. But from a systems biology perspective, all of these other non-pain comorbidities are also omnidirectional with pain, right? And can drive pain amplification. So I don't know what the state of science is for developing, or where the state of the science lies with biomarkers for sleep disorders, mood disorders, fatigue, all of these things. But I would think that those would also be something important to think about and to incorporate into a multi-dimensional biomarker development for pain. And then the second is just a question, which I don't know that any of us can answer, but I'm just curious, having the leaders in the field on this call right now, kind of taking like the 30,000-foot view approach and maybe the funder's perspective, having been involved in HEAL from the beginning and following all the conversations and changes in the biomarker program. Given the fact that we have so many different types of biomarkers and so many, and predictors, as Sean mentioned, and so many different needs, both on a clinical side as well as a basic science side, with limited resources, how do we begin to prioritize where we should put our focus, both from the perspective of what is the scientific and clinical need, but also where has science advanced the most that we could gain most utility in biomarker development?
I love that question and all those comments, and I'm going to maybe direct that to Dr. Sluka, maybe to sort of help us distill down to what would be the and actually I just like, I don't know if I want to say this. I'm going to ask everyone this question because I think Chris Beasley is right on target with this, which is, given there's so many options, right? There's so many things that we can put forward as a committee. There's so many things that NIH can fund in this space. So maybe everyone can sort of say what they think is the biggest gap and the key issue we need to address in biomarkers. Like, where should we put the money? Because of course, money is limited. Where should we put the money? So, Dr. Sluka, you don't have to start, but maybe whoever wants to start that big question, answering the big question.
Well, I'm happy to start, and I'll just do it very broadly. I think we have a great group of experts here, and we know a lot about what's being done. But there's a lot of other people out there that may have a lot of other ideas way outside our thoughts and processes. Maybe from cancer, somebody like Howard will come in and give us a biomarker for pain because he thought this was so interesting. And he'll take a different approach. And so I'd like to see the priorities be very broadly enough based that anybody could come in and do and come up with something novel and different that could drive us to the next stage that we can't think about. I think we could say broadly, we need predictors of successive treatments. I think we need predictors for conversion to chronic pain states. That's how I think about it, because I may have my ideas, but mine might not always be the best. Sean might have much better ideas than me. So that's my 2 cents on it.
I think with that, Sean, you have to answer the question. Please go
Well,
ahead.
first of all, Kathleen's right, but just to provide maybe a perspective, couple things. One is, where are we trying to go with this? Now, Kathleen talked about a little bit about nurturing 1,000 blooming flowers. And I agree with that, because sometimes what comes out of that is like some amazing redwood, or something amazing from a flower. The other is you go for your strategic tactical wins, meaning who's paying the bills here? Well, the taxpayers, but the taxpayers are paying the bills through congressional appropriations. And so ultimately, we want to impress Congress. The NIH wants to impress Congress. So one approach is you take a two-pronged one. You fertilize the 1,000 blooming flowers, but then you go after the most likely win that's going to make a big impact and get a lot of attention. And that may mean picking up the thing that is closest to getting somewhere that's going to have some meaningful impact, that when you deliver on it, it's going to get some great press. It's going to play well to people in Congress. And then you go build on that incremental win to go get more money to feed the machine. So that's a thought that that I was having, is, doing this in parallel. Kathleen and, well, Viv, all of it, you're pretty much more tuned in with the pulse now of where things are healing. Chris, you too.
Well, and Sean, why were you laughing when I was asking the question?
I love the question. I love the question. It's a great question.
Well, I mean,
It's a large unanswerable question. That's why.
ultimately, this is what's going to happen with the work of the strategic plan and these subcommittees, right? Is the funders are going to sit back and try to make some strategic decisions. So, I mean, you can play it's catch 22 here. So for example, from the patient perspective, I highlighted the use of diagnostic biomarkers. Would be great if we had them, but then I also say to myself, but how is that advancing clinical care? Because right now we don't have treatment algorithms for different diagnoses. So if we could create these amazing biomarkers that would separate all these different pain diagnoses, the question still remains, how do we effectively treat those? And so from a consumer-based, public health-based approach, I think to myself, well, that's less of a priority right now than maybe working on the predictive biomarkers of treatment, because then, we would have something to go along with the diagnostic biomarkers, right? So, I mean, and obviously I'm part of your study, Sean, looking at the biomarker study as well. We're looking at, susceptibility of high impact chronic pain, which is super important. But then you ask the question, what are we going to do with that information? Do we have strategies? Do we know that if we intervene early, we can stop the progression of chronic overlapping pain conditions or high impact chronic pain? So there's science for understanding, and then there's science for public and clinical utility. And this is the hard work that the NIH is going to have to do at the end of the day, is to sit back and say, where do we focus our limited resources for different biomarker development? And I totally understand casting the net wide, because you never know what, great ideas and areas of research are going to come in that could lead to, a breakthrough for the field. But I also know pragmatically that, these are the ways the decisions are going to be made in terms of, limited resources and where do we focus. And it also seems to me, again, that some of these areas, and the reason why we've struggled with biomarkers, is because our science hasn't advanced enough yet to be at a place where we can do biomarker work compared to like the cancer field or other fields like that. Not all biomarker work, but certain types of biomarker work.
Thanks, Chris. Peter, did you have a comment on Chris's comment? And then I'd like to go to Christine after that.
Yeah, just a brief comment about diagnostic biomarkers maybe not having immediate utility. I think that really throws down the gauntlet, though, for basic scientists to, if we know what we're aiming at, then that could really accelerate drug development. I think it may not have an immediate use, but it could be a huge payoff in the future.
I would
Great,
second
thank
that.
you. So
And I guess,
Christine, what's on your wish list? Oh, sorry. I was going to go to Christine next, if that's okay.
Oh, do you want to go ahead?
no, go ahead.
So my
No,
wish
please,
list.
Christine.
Thanks. So I think if I'm thinking about my wish list, I would love to see more money going into education and awareness for patients around these issues. I think without their input and their buy-in, that a lot of these things will not happen. I also think one of the things that I look at is, as I go across different silos of industry, is really the proprietary nature of some of the information that's collected. And how can we really build true collaborations that work off of each other to really advance that? So those are my two things in thinking about it, and just from that very different perspective. But I do think involving and having money set aside for education and awareness will help all of us in the end. So, and I think in that education and awareness too, also, patients don't know, right? They're going to think there's answers out there. And we also have to reframe the idea of what research is and find a way to bring that research into clinical care. So, and I'll leave it at that.
Thank you, Christine. Aaron, did you want to go ahead?
Yeah, sorry. I was just going to second what Peter was saying about diagnostic biomarkers. I think that in addition to, laying down the gauntlet for new treatments, I like the way you put that, there may be existing treatments too that failed trials because they were never given to the right patients in the first place. So if we can reduce, if we can use diagnostic biomarkers to reduce heterogeneity in treatment response and separate out groups in trials, those that respond versus those that maybe don't respond or are less responsive, I think that's a win too. So it's not necessarily only future looking if we don't have a new treatment for the condition.
Yeah, and I just want to clarify that I wasn't meaning to say that I don't think that, diagnostic biomarkers are not worth pursuing. I was just using that as one example of how one might weigh, which is ultimately what's going to happen is funders are going to weigh different decisions. They already have in terms of, when the biomarker program started, it was very broad and then it's been narrowed down. Yeah, so I just wanted to clarify that. I didn't want anybody to misunderstand that I was saying that those didn't have a utility and shouldn't be pursued, just using it as an example.
Yeah, no, Chris, I think your point was really well taken, and it's a good conversation to have because, yeah, there isn't, as far as we know, endless money, and we do need to sometimes be specific in how we're answering questions. As Sean said, get some wins and then go get more money. So yeah, so starting with things that we think we can attain. Susan, did you want to just add your point here?
Sure. I mean, this has been a fabulous discussion, and I've certainly learned a lot too. I'm thinking about innovative funding models or mechanisms that could arise from this work around the space of biomarkers to think about things that are not traditionally funded. So, for example, bringing a large trans or multi or interdisciplinary team together to be able to do more around the informatics might involve many of us with large data sets and samples to come together and leverage what we have in the existing space. And that way, to Dr. Sluka's point, there may be things that pop out of a large complex analysis such as that could then be driven to prospective natural history studies or clinical studies or other types of thing, or could be driven back to the animal models that Peter talked about. So I'd like to see some innovation around the funding, less traditional funding mechanisms and study time periods. And the final thing I'll say is I agree with Chris and Christine and very much appreciate their input. I think we've got to engage and involve patient stakeholders and persons with lived experience in these funding mechanisms in very meaningful ways so that we make sure we've got our eye on the prize, so to speak.
Tor, would you like to go ahead?
Sure. Yeah, thanks. This is a great, I'm smiling too, Chris, because this is just a great question. It's like the big question, and there's so many different ways to answer it because it's so big. But I wanted to give a couple thoughts about a few danger points or pitfalls that I feel like I've seen in my experience so far in the field, and then maybe how to avoid those. And I think one of those is the zeitgeist, all the eggs in one basket kind of approach, where a lot of money starts to get funneled towards something that really dominates the field, and that could be public money or private money. And it really is a huge space. And so I really want to echo that we need these small, innovative studies.
That's right.
Yeah, and I think in that space, there's a real problem because my second pitfall is that if you give lots of money for different things, which is generally great, we really need good processes. I think, like you were saying, Howard, for evaluating what's the replicability, what's the reproducibility, what are the benchmarks for rigor. I think that's one of the purposes of, for example, the R61, R33 mechanism is to try to have these benchmarks and hold, stuff like that.
Yeah.
But we need that. And what I've seen is that when you add this idea of, funding lots of different things with the idea that we need clinical applicability right now, you get a lot of approaches that are sort of potentially unrealistic, and they're essentially kind of predatory. And I've seen this, right? Where people, we're going to cure this with this new thing that we're developing in our SBAR. And, so that's why I think we need those processes. And I do also think that I can see there's a lot of benefits to saying we need clinical utility now, but then in many of the places that I see, that is the overarching imperative. And so I just want to also kind of emphasize the need, like a lot of these major transformative discoveries have come from areas that were not focused on clinical utility now, but they developed something that's really important. And I think one of the great examples is people like Carl Dijsselroth and Ed Boynton, who sort of pioneered the discovery of optogenetics, they make a point to do this in their talks over and over again and say there are these, algae. I mean, Rob could give you the lecture on this, right? But that opsins and nobody thought they were going to be so useful, and all of a sudden they're just transforming how we understand the brain in a very fundamental way. So I think that's the just as sort of important, right? To sometimes have a light touch on the clinical utility now. And if I could say one more thing, but like the last thing I'll say is there's another danger point is the big tech black boxification, where like for facial recognition, there's so much power. And Sean, like what Sean's doing with Choir, it's amazing, right? Because you can really mine these data and you can come up with patterns and phenotypes that are really predictive and indicative of maybe it's sleep. And maybe, you go to a sleep lab and you say, oh yeah, you need to do this and this and this. Wow, you can discover that and really have a big impact. But I've seen over and over again, the technologies for doing that and the people who do it are bought up by the tech industry, and they are privatized, and it's gone because it's part of their commercial algorithm. So that's one area, but there's other areas too. So that's where I think is a great use of public money with a commitment to having things really be truly open. And I think, Sean, you've made this point repeatedly across years, which I really appreciate.
Thank you, Tor. Sean, were you going to say something? Or
no, I agree with all of Tor's got it nailed down. I'm wondering in the context of biomarkers, putting out light pivot and getting more data for the NIH All of Us research program is an effort to capture detailed data, not unlike the UK Biobank. Do we feel we as a pain field have enough inroads into that and are getting good quality data that's linking in with what they're doing? I'm coming at that from an uninformed place. But
yeah, and that's one of the great issues I think in the pain field, that we don't have a lot of this initiatives, right? Like that we're able to get our pain characterization on. I don't know the answer to that. If somebody does, please go ahead. I've wondered that myself since we have that at our institution. I've been thinking about it again because of the large amount of data that could not only provide, but also really thinking about the funding, right? Like, you know, why are we using money and you know, to do these things? And actually, I want to make a point that is, you know, really important. I think that, you know, I'm going to add towards sort of challenges and thoughts. I think, you know, not all there's not going to be one biomarker for pain. I think we need to just come to terms with that. So when people think about give me an objective biomarker for pain, I think that is something that I don't believe that is possible. But what I do believe, and following up, Sean, and to your point on, you know, what is it that we should be like low-hanging fruit, right, to move forward. I think what we really need to understand and characterize are what are the phenotypes within the pain phenome that are reliable and valid, and that will really get us to, you know, and again, across the translational continuum, because every time I think, why do we learn about a specific mechanism in an animal preclinical model, is because we have the phenotype down. We know exactly, we've controlled all the things, we've measured it. And so I think, you know, and this is important for what are we putting into this large epidemiological studies, for example, you know, what phenotypes, so what are the questions to give us the phenotypes? So that sort of is my soapbox, because I do think everybody just thinks pain is, you know, is pain. And, you know, for a long time, until we start kind of really talking the same language with what are the phenotypic characteristics, that's what's going to help us, I think, with all the other biomarkers. And so we are, oh my God, we're over. It's 4:01.
I think,
you know,
sorry, Yenisel, I'm just going to say, I think Dr. Giroux, who joined us now, who's co-chair with Dr. Sluka, had one point, and I think we'll end with his point.
You can wrap it up for us.
I want to give one last thing, please.
Okay.
Seriously. I'm much more optimistic now than when I started, because now this is no different than what we do all the time when we're developing a new drug. We define a patient population that's, let's say, relatively homogeneous. Started out, we have, you know, designs related to, you know, we'll say develop a clinical trial, say how many do we need to test to see we're getting a simple signal, and then build it from there. You get, you know, when you talk about clinical utility, that's, you know, I think most of what you're talking about are more diverse populations. I treat prostate cancer. Many of them come in with bone pain that's really hard to manage. That's probably where we'll start. And we can incorporate some of the more molecular mechanisms that come in, because a lot of people have neurologic issues on top. What's their immune system like? We have ways to assess that. And I'm going to work with our consortium and try to put the group together, hopefully with your help, and see if we can start doing that.
Great. Thank you so much. Dr. Giroux, if you want to wrap us up and just
Right. I think, yeah.
a moment over time.
Yenisel and Howard, your comments are a great way to kind of wrap that up. There's not going to be one biomarker, but specific subphenotypes are really important and possible there. I do want to put in, and I'm sorry that I was on another a subcommittee call for most of this, but just put in a marker for biomarkers of target engagement in clinical trials as a you know, we cannot know the reason that a trial failed without being sure that we get target engagement. And so there are some really nicely nominated candidates for which we need biomarkers to make sure that the drug or treatment that we're using are actually hitting the target before we say, well, that's it. This is a failed mechanism, and throw it out. Anyway, this was great conversation. I appreciate everybody's input. Look forward to see what comes out of this. And Yenisel, Viv.
Thank you. Thank you, Rob. Again, yeah, this was wonderful. Thank you, everybody, for your engagement and, you know, your thoughtful consideration. And really, I mean, Viv and I are just very grateful.
Well, Have a great day, and we'll make sure to post the webinar, the questions, everything else will be available on the NIH website, and you'll get an email about that if you registered for the webinar. So thank you again.
Vivian,
Take
do you have
care.
a minute for a question?
Thank you all.
Do you have a minute for a question?
Uh,
Hello?
yeah, I'm already late for a meeting, but yeah, go ahead. I don't know if we're still on the shared webinar, but
I don't know. I can see you, and hopefully
still see you
it seems
guys.
like you're hearing me. No, I think a lot can come out of this, and I'd really like to put a group together to take these through the next steps, because we're pretty good at defining patient populations, and you know, we have a very strong group here at Sloan in terms of pain management, and I think it's doable. We'll just think of it like a phase 2 study. We don't have to do 1,000 patients. We can say X number we'll try. If it doesn't work, we'll continue, go to the next one. And, you know, there are ways to get sources to do those kinds of trials. We're not going for the home run. Let's get on base first. But I've learned